This is the first session that describes gas exchange and transport. The learning objectives are to review the mechanism of respiration, describe the respiratory membrane, list and describe the factors affecting the rate of gas diffusion through the respiratory membrane, and to describe the clinical application of today's lecture. Remember that respiration is the process of inhaling oxygen and exhaling carbon dioxide. It's divided into external respiration and internal respiration. And for the external and internal respiration to occur, it goes through four processes in the form of pulmonary ventilation, exchange of gases, transport of the gas, and then the regulation of breathing. So always remember that the steps of the external respiration include ventilation, or the gas exchange between the atmosphere and the alveoli in the lung, then the exchange of oxygen and carbon dioxide between the air in the alveoli and the blood, then transport of oxygen and carbon dioxide between the lung and the tissue, then the exchange of oxygen and carbon dioxide between the blood and the tissue, which is the actual internal respiration. All these steps are regulated by the respiratory center in the medullary region. So, what is gas exchange? Gas exchange in the respiratory system refers to the diffusion of oxygen and carbon dioxide in the lung and in the peripheral tissues. Oxygen is transferred from the alveolar gas into the pulmonary capillary blood and ultimately delivered to the tissue, where it diffuses from the systemic capillary blood into the cell, where carbon dioxide is delivered from the tissue to the venous blood to the pulmonary capillary blood, and it's transferred to the alveolar gas to be exhaled. The exchange of gases between the alveolar air and the venous blood occurs in the pulmonary capillaries along a specific membrane known as respiratory membrane. The respiratory membrane separates the air inside the alveoli from the blood inside the pulmonary capillaries, so the gases will diffuse through it during external respiration. The respiratory membrane is composed of 6 layers. It includes a layer of fluid lining the alveoli and containing surfactant that reduce the surface tension of the alveolar fluid, the alveolar epithelium, which is formed of one layer of epithelial cells, an epithelial basement membrane, a very thin interstitial space between the alveolar epithelium and the capillary membrane, a capillary basement membrane, and the capillary endothelial cells. Despite the large number of layers, the thickness of the respiratory membrane is as little as 0.2 micrometer, with an average of 0.6 micrometer. The average surface area of the respiratory membrane in both lungs is about 70 square meter. The gas exchange across the cell membrane or the capillary wall occurs by simple diffusion. Now, what are the factors affecting the gas exchange? Or in another word, what are the factors affecting the simple diffusion of a gas across the cell membrane or the capillary wall? Well, the rate of transfer of a gas by a simple diffusion across the membrane is directly proportional to the driving force, which is the difference in the partial pressure of the gas between the alveoli and the pulmonary capillary. Also, it's directly proportional to the diffusion coefficient and to the surface area available for the diffusion. It's inversely proportional to the thickness of the membrane. Note that the diffusion coefficient of a gas depends on the molecular weight of the gas and the solubility of the gas. So we can combine all the factors that affect the gas exchange by saying that the diffusion of the gas is directly proportional to the driving force, which is the difference in the partial pressure of the gas between the alveoli and the pulmonary capillary, directly proportional to the A, which is the surface area of the membrane, directly proportional to the S, which is the solubility of the gas, inversely proportional to the D, which is the distance that the gas will cross through it, which is the thickness of the membrane, and inversely proportional to the square root of the molecular weight of the gas. Now we'll start discussing the factors affecting the gas exchange, and we start with the driving force, which is the difference in the partial pressure of the gas between the alveoli and the pulmonary capillary. When the partial pressure of the gas in the alveoli is greater than the pressure in the blood as with the oxygen, the net diffusion from the alveoli into the blood occurs. But when the pressure of the gas in the blood is greater than its partial pressure in the alveoli as for carbon dioxide, the net diffusion from the blood into the alveoli occurs. So, looking at this table that shows the different partial pressure of oxygen and carbon dioxide in the pulmonary capillaries and alveoli, we'll find that the partial pressure of the oxygen in the alveolar air is 100 millimeter mercury, while the partial pressure of oxygen in the pulmonary capillary, the mixed venous blood, is 40 millimeter mercury. So the pressure gradient is 60 millimeter mercury, which is a driving force that moves the oxygen from the alveolar air from the high partial pressure to the low partial pressure in the pulmonary capillary. Looking at the carbon dioxide partial pressure in the pulmonary capillary, it's 46 millimeter mercury, while in the alveolar air it's 40 millimeter mercury. So the pressure gradient or the pressure difference is 6 millimeter mercury. It's a driving force for the carbon dioxide to move from the high partial pressure in the pulmonary capillary to the low partial pressure in the alveolar air, where it will be exhaled. Always remember that the main driving force for the gas diffusion is the difference in the partial pressure of the gas between the alveoli and the pulmonary capillary blood. When the partial pressure of the gas in the alveoli is greater than the pressure in the blood as with the oxygen, the net diffusion from the alveoli into the blood occurs. But when the pressure of the gas in the blood is greater than the partial pressure in the alveoli as with carbon dioxide, the net diffusion from the blood to the alveoli occurs, and this is how the blood is reoxygenated. The next factor that affects the gas exchange is the surface area of the respiratory membrane. The surface area of the respiratory membrane is about 70 to 100 square meter in both lungs of an adult. The surface area of the respiratory membrane increases during exercise due to the fact that during exercise there is more expansion of the alveoli, more dilatation of the pulmonary capillaries, and more opening of the closed capillaries. Yet, the surface area decreases in old age due to decreased number of open capillary, in cases of removal of the lung or part of it, in case of emphysema because many alveoli collect together with loss of the alveolar wall, so we'll have new chambers that are roomy but with less surface area of the alveolar wall. Also, the surface area of the respiratory membrane decreases in cases of obstruction of the bronchus or restrictive lung disease. It's important to note that when the total surface area is decreased to 1/3 or 1/4 of its normal, the defect in the gas exchange is observed even during rest. The next factor that affects the gas exchange is the solubility of the gas. The more the solubility of the gas, the faster it will diffuse across the respiratory membrane. Note that carbon dioxide diffuses 20 times more than the oxygen, since its solubility is higher than that of the oxygen and the molecular weight of both gases are not so different. The next factor that affects the gas exchange is the distance that the gas will cross through it, which is the thickness of the membrane. The thickness of the respiratory membrane is as little as 0.2 micrometer with an average of 0.6 micrometer. The rate of the gas diffusion is inversely related to the thickness of the membrane. The thickness of the membrane should be increased up to 2 or 3 times more than its normal value to interfere with the gas exchange, and this can occur in cases of pulmonary edema and lung fibrosis. The thickness of the membrane can be decreased in deep breathing during exercise, so the diffusion will be increased significantly. The next factor that affects the gas exchange is the square root of the molecular weight. The rate of diffusion of the gas is inversely related to its molecular weight. Note that several of the terms in the previous equation for the diffusion can be combined into a single term called the lung diffusion capacity. The lung diffusion capacity combines the diffusion coefficient of the gas, the surface area of the membrane, and the thickness of the membrane. The lung diffusion capacity takes into account the time required for the gas to combine with the protein in the pulmonary capillary blood. That's to say, the binding of oxygen to hemoglobin in the red blood cell. Now we will be discussing an important factor affecting the gas exchange, which is the ventilation-perfusion ratio. The ventilation-perfusion ratio is the ratio of the alveolar ventilation, which is 4 liters per minute, to the pulmonary blood flow, which is the perfusion, 5 liters per minute. Matching ventilation to perfusion is critically important for ideal gas exchange, as it is useless for the alveoli to be ventilated but not perfused, or for the alveoli to be perfused but not ventilated. So, what is the normal value for the ventilation-perfusion ratio? The normal value for the ventilation-perfusion ratio is 0.8. This value means that alveolar ventilation is 80% of the value of the pulmonary blood flow. The term normal means that if the breathing frequency, the tidal volume, and the cardiac output all are normal, the ventilation-perfusion ratio will be 0.8. In turn, if the ventilation-perfusion ratio is normal, then the partial pressure of oxygen in the arterial blood will be its normal value, which is 100 mm mercury. And the partial pressure of the carbon dioxide in the arterial blood will be of its normal value, which is 40 mm mercury. If the ventilation-perfusion ratio changes due to any alteration in the alveolar ventilation or an alteration in the pulmonary blood flow or in both, then the gas exchange will be less than the ideal, and the value for the partial pressure of the oxygen and carbon dioxide in the arterial blood will change. The value of 0.8 for the ventilation-perfusion ratio is an average for the entire lung. Now remember that we said the value of 0.8 for the ventilation-perfusion ratio is an average for the entire lung. In fact, in the 3 zone of the lung, the ventilation-perfusion ratio is uneven. Due to the effect of gravity, zone 1 has the lowest blood flow and zone 3 has the highest. The alveolar ventilation also vary in the same direction among the zone of the lung. Ventilation is lower in the zone 1 and higher in zone 3, again due to the gravitational effect in the upright lung. So, due to the gravitational effect in the upright lung, we'll find that as we go down from zone 1 to zone 3 in the lung, both the perfusion and the ventilation increase. But the increase in the perfusion is much more than the increase in the ventilation. Therefore, the ventilation-perfusion ratio is highest in zone 1, it's 3, and the lowest in zone 3, it's 0.6. with an average value for the entire lung being 0.8. These regional differences in the ventilation-perfusion ratio produce regional differences in the partial pressure of oxygen and carbon dioxide in the blood. In zone 1, where ventilation-perfusion ratio is highest, the partial pressure of oxygen is highest and the partial pressure of carbon dioxide is lowest. In zone 3, where the ventilation-perfusion ratio is lowest, the partial pressure of oxygen is lowest and the partial pressure of carbon dioxide is highest. These regional differences are present in healthy lungs, and the blood leaving the lung via the pulmonary vein has an average partial pressure of oxygen of 100 mm mercury and an average partial pressure of carbon dioxide of 40 mm mercury. Normally, there is a ventilation-perfusion matching. That's to say, the ventilated alveoli are close to perfused capillary, and this arrangement provides for ideal gas exchange. Although there are regional variation in the ventilation-perfusion ratio, yet the average value for the whole lung is about 0.8. A mismatch of the ventilation and perfusion is called ventilation-perfusion mismatch or ventilation-perfusion defect, which results in an abnormal gas exchange. A ventilation-perfusion defect can be caused by ventilation of lung region that are not perfused, that's to say it's a dead space, or Perfusion of lung region that are not ventilated, that's to say, an area of shunt. So remember that a mismatch of the ventilation and perfusion is called ventilation-perfusion ratio mismatch or ventilation-perfusion ratio defect, which results in abnormal gas exchange. The ventilation-perfusion ratio defect can be caused by ventilation of lung region that are not perfused, that's to say a dead space, or perfusion of the lung region that are not ventilated, that's to say presence of an area of shunt, and every possibility in between. Now we will discuss dead space. Dead space is ventilation of lung region that are not perfused. This ventilation is wasted or dead. No gas exchange is possible in the dead space because there is no blood flow to receive oxygen from the alveolar gas or to add carbon dioxide to the alveolar gas. Dead space can be seen in cases of pulmonary embolism. Now we will discuss the high ventilation perfusion ratio. Regions of high ventilation-perfusion ratio have high ventilation relative to perfusion, usually because the blood flow is decreased. Unlike dead space, which has no perfusion, high ventilation-perfusion ratio regions have some blood flow. Because ventilation is high relative to perfusion, pulmonary capillary blood from these regions has a high partial pressure of oxygen and low partial pressure of carbon dioxide. Now we will discuss the low ventilation perfusion ratio. Regions of low ventilation perfusion ratio have low ventilation relative to perfusion, usually because ventilation is decreased. Unlike the shunt, which has no ventilation, low ventilation perfusion ratio regions have some ventilation. Because ventilation is low relative to perfusion, pulmonary capillary blood from these regions has a low partial pressure of oxygen and high partial pressure of carbon dioxide. Now we will discuss the shunt. Right to left shunt is perfusion of lung regions that are not ventilated. No gas exchange is possible in regions of shunt because there is no ventilation to deliver oxygen to the blood or carry away carbon dioxide from the blood. The shunt can be seen in cases of airway obstruction and in the right to left cardiac shunt. Now it is important to ask ourselves an important question. Is there a compensatory mechanism for the ventilation-perfusion ratio defect? In another word, is there an autoregulation done by the body to overcome the defect in the ventilation-perfusion ratio? The answer is yes. In cases of hypoxia, the decreased partial pressure of the oxygen in the capillary draining poorly ventilated alveoli causes arteriolar vasoconstriction. This results in redistribution of the blood to the capillaries of well-ventilated alveoli. Keep in mind that this is contrary to any other place in the body, as normally the hypoxia will induce vasodilatation. Now, what is the clinical application of today's lecture? We should ask ourselves what is the clinical application of knowing the lung diffusion capacity? The clinical application of knowing the lung diffusion capacity is, in emphysema, for example, the lung diffusion capacity decreases because the destruction of the alveoli results in decreased surface area of the gas exchange. Another clinical application of knowing the lung diffusion capacity is in cases of fibrosis or pulmonary edema. The lung diffusion capacity decreases because the diffusion distance, that's to say the membrane thickness, increases. Also, the cases of anemia is another clinical application of knowing the lung diffusion capacity. As in anemia, the lung diffusion capacity decreases because the amount of hemoglobin in the red blood cell is reduced. Also, it is important to know that exercise is another clinical application of knowing the lung diffusion capacity, as during exercise, the lung diffusion capacity increases because additional capillaries are perfused with blood, which increase the surface area for the gas exchange. Also, we should ask ourselves what is the clinical application of knowing the ventilation-perfusion mismatch? One of the clinical applications of the ventilation-perfusion ratio mismatch is the chronic obstructive lung diseases, seen in chronic smokers, for example. The chronic obstructive lung disease leads to some area shows bronchoconstriction, so the ventilation and the ventilation-perfusion ratio are decreased, causing serious shunt. Other areas shows destruction of the wall with inadequate blood supply, thus decreasing the perfusion, and a serious dead space appears. Also, pulmonary emboli is another example of the ventilation-perfusion ratio mismatch. In pulmonary emboli, the thrombosis decreases the perfusion, so the ventilation-perfusion ratio is increased, but this is followed by bronchoconstriction of the affected area, causing shifting of the air to the normally perfused alveoli with subsequent improvement of the ventilation-perfusion ratio. So always remember that the cases of the airway obstruction are examples of the shunt, while the cases of the pulmonary emboli are examples of the dead space. Also remember that changes in the alveolar capillary membrane can cause diffusion limitation, such as cases of emphysema, fibrosis, pneumonia, and pulmonary edema. By this, we finish today's session. Hope that you enjoyed it. Thank you.